Hello friends. So after having dealt with the pathophysiology and the clinical features in a case of diabetic ketoacidosis, now we'll be moving on to the management of diabetic ketoacidosis. So the management includes both your investigation and the treatment part. So what are the investigations are you going to do in a case of a patient with diabetic ketoacidosis? Okay. So what are the investigations? Okay. Now you see that whenever a patient comes to us with a case of suspected diabetic ketoacidosis, we actually identify it from the signs and symptoms that we have discussed in the earlier of the part of this video. So we go for certain investigations. So what are those investigations? Of course, number one, you have got hyperglycemia, right? So for hyperglycemia, you have to go for a CBS. Now, usually the CBS is the capillary blood glucose. So you do it exactly immediately as soon as the patient is admitted, and also it has to be done at regular intervals. Now why at regular intervals? Because when these patients comes, we have to start them on insulin infusion. So we have to monitor the insulin infusion, like we have to monitor the blood sugar, and we have to adjust the dose of insulin infusion accordingly. Also on top of that, we said the patient has got a ketonemia and ketonuria. So for that, what we have to do, we have to see the serum ketone levels. Okay, serum ketone levels. So it's a blood test. It can be done from the serum. Another thing is that we have to go for a urine ketone body. Now urine ketone body, uh, it can be done by two ways. So one is, well, we do it very easily or by bedside, which is the qualitative method. We take the urine sample of the patient. We take it in a maybe a test tube or maybe a urine container, and what we do is we dip a dipstick strip. Okay, so this dipstick strip has got some color codings. Okay, so on the basis of that color coding, we match with the color on the bottle of the dipstick, and accordingly we say whether the patient has presence of ketone body or not. Okay, next we move to the presence of acidosis. So how we will say the whether the person has got an acidosis or not? So what we do, we go for an ABG. So ABG stands for arterial blood gas. ABG stands for arterial blood gas. So arterial blood gas will give you something known as pH. So if the pH is usually less than 7.35, so we can say the patient is into acidosis. And in this case, the acidosis is due to the ketoacids in the blood. Another thing is we need to go for checking of the electrolyte parameters, because as we said, the patient can land up into electrolyte disbalance or metabolic complications. So the patient can land into hyperkalemia or hypokalemia accordingly. And also when we start the fluid resuscitation therapy, since a large volume of the fluid has to be given, so we also have to monitor for presence of hypo and hypernatremia. Also on top of that, we also have to monitor for the presence of any AKI. Okay, because the patient is grossly dehydrated in these cases, so we have to go for an urea and creatinine levels in this patient, because the patient can now land up with an AKI due to the gross dehydration. On top of that, also we have to go for the basic test like CBC, which is the complete blood count, because the TLC might be increased in cases of infection. Now why infection? Because see, two things. One is the fact that any infection can trigger a diabetic ketoacidosis in a type 1 diabetic patient. And the second factor is that a diabetic patient who is presenting with a hyperglycemia, very uncontrolled blood sugar, they are very much immunocompromised, and they can acquire any kind of secondary infections. Fine. So you also have to go for CBC, and then for sepsis screening, you can go for a chest X-ray, you can go for an urine RE and CS. Also, you can go for a blood CS, and you can also go for something like a like procalcitonin if a infection is suspected. Fine. On top of that, you can also at times can go for amylase lipase, but they can be raised in diabetic ketoacidosis, but they can be usually mildly raised, but they does not suggest any kind of pancreatitis in case of diabetic ketoacidosis. Okay. Now, next is the management. So, how do we manage a patient of diabetic ketoacidosis? So, this is very something very important. Now, why it is important? Because you will get many patients of like this sort in your hospitals. Okay, be it in the emergency or be it in the ward, you will get many patients who land up into diabetic ketoacidosis, mainly the patients of type 1 diabetes. Okay, so usually what are the goals? I'll say, if I ask you like what are the goals of uh, diabetic ketoacidosis, like what are the things that need to be managed? What are my targets basically? If I were to ask you, then you would say me like the goal should be number one, that I have to correct the dehydration. So one has to be the treatment of dehydration, right? Treatment of dehydration. Now, see, when I am, how do I treat this dehydration? See, I have three things. One is sodium chloride, which is like 0.9%. Another thing I have is sodium chloride again, but then it is 0.45%. And another thing I have got ringer lactate. So see now, thing is that most of the places you start the fluid resuscitation with the sodium chloride. Now, for starting sodium chloride, you also have to keep it into mind that so to start with fluid resuscitation, you also have to keep it into mind that you have to consider the volume status of the patient, volume status of the patient, and also you have to monitor for the cardiac and renal status. Now, why these two are very important is because, see, the person may have a very low cardiac output of something like 35, 40, 45%. Okay. So, which is not normal, which is like below par, and also might have a maybe grade 3, 4, or like grade 5 CKD. So in those cases, when we are doing the fluid resuscitation, we have to do it very judiciously. We cannot follow the protocol of a norm of the fluid resuscitation that we would have followed in a case of normal person. Okay, so how do we do that? We usually can start with something like we can start with an isotonic sodium chloride, or we can start with a ringer lactate. Ringer lactate. Okay, so we can start with that. Then how do we usually give this? So how do we give this? So usually what we say that in the first hour, if the person have normal volume status, now volume status these days we can measure with the IVC volume, or the change in the like size of the IVC on inspiration and expiration. So wow, after measuring the volume status, we can start with the full fluid resuscitation, and in the first hour we usually give like nearly up to 2 liter of fluid. In the second hour, what we do is in the second hour we do again another liter of fluid, and in the next 2 hour, in the next 2 hour, okay, in the next one, that is the third and fourth hour, we give another liter of IVF fluid. Okay, next what we do is again we go for a maintenance fluid. So this part is to resuscitate the volume, to correct dehydration, right? To correct the acute dehydrated state, dehydration. Okay, to correct this acute dehydrated state. Now, next, what we do is that we go for something like the maintenance fluid. So, how do we give the maintenance fluid? The maintenance fluid usually that we follow is like we can give 1 liter of fluid like every 4 to 6 hours, we can give 1 liter of fluid. Okay, we can give 1 liter of fluid every 4 to 6 hours. But see, I always say that be very judicious while you are correcting the fluid, because you should not land up your patient into a heart failure or renal failure for that matter. Or well, I shouldn't be saying renal failure. Heart failure is a common finding, and also into volume overload status. So be very judicious, I would say. But then at the same time, these are the standard things that you can follow. Next, what you can do is when the patient has reached a euvolemic status, so when patient comes euvolemic. So when the patient is euvolemic, what do you do? So you start giving something like a half NaCl, or which is also known as 0.45% sodium chloride. So half normal NaCl. Particularly, you have to you do this when since a large volume of this fluid is given, since a large volume of fluid you are giving. So what happens? The patient might land into something, a problem of known as hypernatremia. Natremia. So, what is hypernatremia? Hypernatremia is increase in serum sodium of more than 145. Now, thing is that when the patient, sorry, patient lands up into something like an hypernatremia, we have to prevent that, and as a preventive measure, we have to use 0.45% sodium chloride. Fine. Now, uh, next, what we have to see is that when VCC, another part of the fluid resuscitation therapy is when blood glucose, when blood glucose reaches somewhere between maybe when blood glucose reaches somewhere between 180 to 200 milligrams per DL. Okay, when blood glucose reaches somewhere at this level, you start with what? 5% or 10% dextrose. Okay, 5% or 10% dextrose. Why? Because the patient can have hypoglycemic episodes when the patient is on insulin infusion. Okay, so the patient can have hypoglycemic episode when the patient is on insulin infusion. Fine. Next, what we do is we go for the correction. Okay, so this was the correction of dehydration. So what is the second point? We go for the correction of potassium imbalance. So potassium balance correction. Okay, so how do we correct potassium in this patient? How do we correct? So, as soon as you give this insulin, what happens is potassium comes whenever insulin comes into play. Whenever insulin comes into play, what happens that potassium from the extracellular space comes and moves into inside the cell. So what happened? You might land up into something, a very problematic situation known as hypokalemia. Now, why hypokalemia is very important? Because hypokalemia are notorious and are known to cause many problems. Among them, a life-threatening condition can be arrhythmia. Okay, so a life-threatening condition is arrhythmia. So how do you treat the potassium imbalance? So what we do basically in our wards or ICUs is that we start the potassium supplementation. Usually, as soon as we start with the insulin infusion. So what we say that KCl infusion, potassium chloride solution infusion should be started from the beginning. Why? Because the potassium rapidly moves into the cells causing extracellular hypokalemia. Okay, so how do you correct this potassium? The potassium is added uh, into the so how do you do this? KCl infusion, or you can use that KCl plus IV fluid. So we can put the KCl into the bottle of the IV fluid and we can start this infusion. Now, roughly, it is said that when you measure this potassium, if the potassium level is greater than is equals to 6 milliequivalent per liter, we do not give a supplementation. No supplementation. Okay. Uh, Next, what we do is when potassium level is somewhere between 4.5 to 6 milliequivalent per liter, we give potassium infusion at a rate of 10 milliequivalent per hour. Okay, and when the potassium level is somewhere between 3 to 4.5 milliequivalent per liter, we give potassium at a rate of 20 milliequivalent per hour. Now, For your like knowledge, what I would like to say is that uh, the vials of potassium that is available in the wards, I would say. So usually these vials contain 10 ml of potassium chloride, and this 10 ml of potassium chloride contains 20 milli equivalent of potassium, 20 milli equivalent of potassium. So when I'm saying 20 milli equivalent per hour, it means that 10 ml of potassium chloride of the standard potassium chloride solution has to be given in 1 hour. But again, I'll say you that we don't give so much of potassium in our actual practice. We rather be more judicious and cautious while we give the potassium. We usually don't follow such high amount of concentration, just so that the patient does not land up in hyperkalemia. So we usually have to monitor potassium level. So we have to give potassium at a slower pace. Okay. Next, what we see is we have to, from the ABG, we know that the patient has landed up into something known as ketoacidosis. Ketoacidosis. Now, how do we correct this ketoacidosis? Now, you see, one thing you have to know that you don't really need to correct the ketoacidosis. Now, what I'll say that whenever you start the patient on the insulin therapy, you correct the blood glucose, you correct this potassium, you give the ventilatory support if at all required into the patient, the blood parameters or the ABG gets corrected automatically as soon as the dehydration and the other parameters get corrected. But at times it might just happen that the patient can land up into something known as decompensated acidosis, compensated, or I can for that matter say severe acidosis. Now in those cases, what you can do a sodium bicarbonate administration, right? You can do something like a sodium bicarbonate administration. Okay. Next, what we do is that we have to treat we have to treat the abnormal glucose level. Fine. Abnormal glucose. Abnormal glucose. So what is this abnormal glucose? This is actually the hyperglycemia. Hyperglycemia. Now, I have already told you that for hyperglycemia, what you need to do. So for hyperglycemia, what we start with insulin infusion. Okay, so we start with insulin infusion. So it has to be started bedside, and on top of that, we have to monitor glucose every hour, monitor CBS every hour. And one more thing is that we use normally we use regular insulin. So regular insulin. Now regular insulin, is a short acting insulin. Okay, so regular insulin is a short acting insulin. Now, for your knowledge, I would say that in the standard vials that we get in the our uh, wards on ICU, is that these insulin bottles, they come in a standard concentration of 1 ml is equals to 40 units of insulin. So what we do is that we take you for the insulin infusion, we take something like 39 ml of 39 ml of sodium chloride, and we mix it with 1 ml of insulin. So we try to make a solution which is 40 ml of solution containing 40 units insulin. Okay, so this is the standard consideration we try to achieve, and then we try to start the infusion at 1 ml per hour or like 2 ml per hour. Okay, so 1 ml means 1 units, 2 ml means 2 units. Okay, after the reconstitution, and then we try to infuse it as per the what is known as a sliding scale. So what is the next thing that next thing is we also have to use something like an antibiotic. Antibiotic is the uh, empirical antibiotics. So why you have to do is that number one is, as I already told you, because it is that the patient can have something like a critical infection. Okay, which might have triggered this diabetic ketoacidosis, or the patient can have something like a I'll say diabetes and diabetic ketoacidosis, and then patient can end up into some secondary infections. Okay, because when the patient is having this diabetic ketoacidosis, their immunity is very much compromised, and the patient can land up into more critical conditions. So for that, we have to use antibiotics. Also, when the patient is bedridden for the longer time, we have to use something known as anticoagulation. So for anticoagulation, we use heparin. Okay, so we use something like a heparin, or we can use something like a LMHW, which is the low molecular weight heparin. So, for your clinical knowledge, let me tell you that we use heparin when there is suspected AKI or like CKD, and when there is nothing as such, we can use a low molecular weight, something like a Clexane. Can use something like a Clexane. So, why this anticoagulation is used? Because the patients are usually bedridden for the long time, bedridden for a long time due to this illness, or also it can happen that the patient can have a hyperviscosity due to dehydration. Okay, so this hyperviscosity due to dehydration usually causes what? They usually causes a DVT, which is the deep vein thrombosis, which is the accumulation of blood clot in your lower limbs. Okay, so that's all for this management part. And also, after the patient is stable, you also have to go for a plan where you will be managing going for the management of the diabetic status of the patient on the long term basis. So just for the mnemonic, so as I said, the D, K and A, diabetic ketoacidosis. So this is treatment of dehydration. Another K stands for potassium imbalance. Another K stands for ketoacidosis correction. Another then DKA. So A stands for abnormal glucose, which is hyperglycemia, and A for antibiotics, and A for anticoagulation. So that's all for this video. If you have liked this video, you can I mean, if it has helped you, you can like this video and put a thumbs up.